ethics grand rounds of this new academic year. My name is Jackie Glover. I'm co-director of the Ethics Consult Service at the University of Colorado Hospital with my friend and colleague, Dr. Kristen Farfari. Ethics Grand Rounds is sponsored by the Ethics Committee at the University of Colorado Hospital and also the Center for Bioethics and Humanities. And on behalf of everyone, welcome. We are so pleased to have this topic and this speaker to start us off. I'm a gray hair, so I remember when slow codes was a thing. And so when we saw it in literature, I said, is that still a thing? And we said, let's get Abby to talk about it with us. And so I hope you find this topic as provocative as I do. The title is, Does the Tempo of Codes Matter? The Ethics of Slow Codes. So at the end, you should be able to define slow codes and whether or not they still exist, why they occur if they do, the ethical issue involved in complex code situations, and identify resources to help address ethical issues. So to help us understand this interesting and important topic is Dr. Abby Laurel. She's an associate professor of medicine in the Division of Pulmonary Sciences and Critical Care Medicine. She's the medical director for health equity at UC Health, and she's the co-director of the Office of Professional Excellence here at the University of Colorado School of Medicine. Welcome, Dr. Laura. Oh, and please put your comments, questions in the chat.
Great. Well, thank you so very much. It's nice to see everyone, and I appreciate the invitation today. So with that, I want to make sure that I leave enough time towards the end. Going to get started. All right. So as Dr. Glover mentioned, I'll be walking us through these objectives that she's just talked about. But as we start with ethics grand rounds at the start of the academic year, we're going to begin with a case. And this case is of a 62-year-old male whose only past medical history is relevant for hypertension. He had been brought into the emergency room here at UC Hospital by his wife, and he had two complaints. One was generalized weakness, and the second was shortness of breath. He was empirically treated for community-acquired pneumonia because of this chest X-ray, which demonstrates some infiltrates, alveolar infiltrates, here at that left base. Following his initial hospitalization and evaluation, he rapidly clinically deteriorated. He developed acute hypoxic respiratory failure, and he was intubated and ultimately transferred to the medical intensive care unit. Over the course of the hospital days 2 through 12, he developed severe ARDS, or adult respiratory distress syndrome. We utilized our standard methods to support individuals with severe refractory hypoxic respiratory failure, including mechanical ventilation using lung protective strategies. And we also employed early prone positioning and paralytics to help optimize his oxygenation status. I recognize for some on this call, though that might be a little bit of lingo that you don't understand, but suffice it to say, these are extreme strategies that we use that are evidence-based to help support our patients who are mechanically ventilated. He developed cardiovascular shock and required hemodynamic support. And ultimately, he developed some renal failure as well and was on dialysis. So for those of you who might not understand what a code is or cardiovascular resuscitation, I thought it would be important to define what cardiovascular resuscitation is. So what we refer to in the hospital as a full code or a code blue is when an individual comes into the hospital and if they have a clinical deterioration in which their heart is to stop or they're unable to breathe on their own and they wish to have full resuscitative efforts, that's what we refer to as a full code, When that patient stops breathing or their heart stops, a code blue is called. And this involves calling a code team, which is made up of a multidisciplinary group of healthcare workers, all the way from the ICU resident, who is the code team leader, all the way up to the attending in the ICU. We have spiritual care, pharmacists, respiratory therapists, anesthesiologists, etc. This group of team members are called quickly in order to initiate appropriate therapy in a very quick and effective fashion. The goal is to reverse the underlying adverse event and return the patient to a status that is consistent with life. And we try to do this as quickly as possible in order to try to restore the high level of functioning of the patient following a cardiovascular or respiratory arrest. It's considered an emergency intervention with a very high priority, and speed is of critical importance in these situations. And if effectively executed, it can very much be life-saving. The corollary, however, which is what Jackie was talking about earlier, is what is a slow code? So a slow code occurs in which the resuscitative efforts by the healthcare team or the code team is carried out in too slow of a fashion in order for that individual to receive resuscitative efforts or to survive a code. But there's a variety of other interpretations as well in regard to what a slow code is. It can also be considered a symbolic event conducted by the healthcare professionals in which advanced life support is not conducted to its full extent. It could include limiting the number of interventions, the duration of the interventions, and the intensity of the interventions, or a combination of all three. Slow codes are thought to include some resuscitative efforts, but again, carrying them either too slowly or omitting some of the most aggressive in order to allow that patient to potentially expire or not actually survive the code event. Other terminology that I've seen in the literature, or you may have seen on TV besides slow codes, include Hollywood codes or show codes. Identification of slow codes was first found by Jessica Mueller in 1992. And this is when she evaluated the practice of a slow code, a partial or abbreviated resuscitative event at the University of California in San Francisco. And in this particular study, she evaluated why slow codes would occur in this academic center. She surveyed residents, nursing staff, and faculty, and ultimately she found 4 situations in which slow codes occurred in this academic center. And they're listed here. Disagreement between families and the healthcare team in regard to the appropriate use or continuation of medical care. There was disagreements between the residents and senior attendings in regard to whether or not aggressive medical treatment should be pursued. Differing interpretation status of what DNR status or full code status is for a patient, either from the patient's perspective, the family's perspective, and that was often in conflict with the healthcare team as well. And then finally, discussion of the DNR status simply didn't occur, either because of the contentious nature of the relationship between the healthcare team and the family, or there was never an opportunity for those conversations to occur. So when thinking about applying the principles of ethics in regard to codes, Dr. Kelly did a meta-analysis to review what are the factors that could contribute to the practice of a slow code or the decision to have a slow code occur within the healthcare setting. In thinking about the principle of non-maleficence, we think about slow codes as potentially being able to spare the patient the indignity of surviving a disastrous level of survival if the full resuscitative efforts were instrumented. It can also prevent inadequate care of the patient if that DNR order was placed, or to avoid a patient and their family members from becoming distressed by having the conversation of no code or DNR status. DNR meaning do not resuscitate. In thinking about the principle of beneficence, slow codes can occur because we want to reassure that the family that everything is being done in order to ensure that the healthcare team is taking action to help support the patient. It could be a symbolic or ceremonial intervention to help maintain the hopes of the family and the patient, and also to prevent patient suffering because of inappropriate CPR decision-making by a more experienced clinician or provider. In thinking about the principle of autonomy, it can be in thinking about using slow codes and the sorry, in thinking about the principle of the ethical framework of autonomy, slow codes can be considered if, in order to provide the family and the patient the illusion of being autonomous. It can also be used, unfortunately, to circumvent the patient's and family's unrealistic view of CPR. And it can also be used to circumvent the families and patients' religious convictions or spiritual convictions. And then finally, in thinking about the ethical framework of justice, slow codes, decision to perform a slow code could also be to simply redirect finite resources to more salvageable patients, or to limit the expensive treatments, particularly in the ICU setting, in order to provide a successful exit, if you will, from a devastating disease or a devastating event. So these were all reasons that had been identified in the literature up to 2009 in regard to why slow codes occur, the decisions to do slow codes, and identifying the reasons why they could occur from an ethical standpoint. But it's 2021. And so as Jackie and I have had conversations about codes because we partner quite closely in a variety of settings, and I work in the medical intensive care unit, we had discussions about whether or not they continue to exist. And I recently reviewed this manuscript for the bioethics committee. And this particular manuscript identified the use of slow codes and the medical futile codes and whether or not they occurred in clinical practice. So the hypothesis is that slow codes are considered to continue to occur in clinical practice, even though many physicians and clinicians would ethically disagree with their use. So this particular group did a two-center cross-sectional study where the primary aim was to describe the use of slow codes in clinical practice. The secondary aim was to identify and describe the association of slow codes and medically futile attempts in resuscitation and cardiovascular resuscitation with the attitudes, and to determine if moral distress of medical professionals occurred, as well as to evaluate why slow codes occurred. The overall study design was survey. A survey was sent out via email. It was a 28-item survey, and I'm happy to share this manuscript at the end of the talk. The participants included all internal medicine residents at 2 academic centers, Rush University and the University of Chicago. It also included specialty fellows, cardiology and pulmonary and critical care fellows, attendings in those 2 specialties, and of course, nursing staff and advanced practice providers as well. Each of the participants was also provided a clear definition for what a slow code meant in regard to this survey, as well as what moral distress, how it was defined in this particular survey. There were 3 emails that were sent over the course of a month, and participants were encouraged or incentivized to complete the survey by entry into a raffle to receive a gift. The 28-item survey included multiple choice responses, as well as a 5-point Likert scale, and the ability to provide free text response as well. What's shown here is the respondent characteristics along with the response rate. So overall, the response rate for all participants was 31%. Of those who responded, the vast majority were the internal medicine residents at 48%. Nursing staff was next, followed by the specialty attending and specialty fellows, each of which had a response rate of approximately 10%. Those for all those in clinical practice, the vast majority of the respondents were in clinical practice at the bedside for less than 10 years. 43% were aged less than 30, whereas 45% were aged between 30 and 39 years of age. The vast majority were white by demographics, and in gender were female. And what follows is the reports of whether or not each of these participants had observed or experienced or witnessed a slow code. And what you can see here is 69% of the participants all have said that they have either performed or witnessed a slow code being performed on a patient that they cared for. And the majority of those slow codes occurred in the medical intensive care unit at 49%. Overall, the reported mean of codes occurring in the past year per respondent was approximately 1.3. Oops. In regard to the individual who requested the codes, the vast majority at 84% were requested by an attending physician. There was not a significant statistical difference between the specialty of the attending, the profession, age, or in years of practice for all those who reported involvement or requesting the codes. What I thought was interesting as well was in regard to the length of time in which the resuscitation attempt was reported. Remember, this was a survey that was sent out. And so this particular question asked the participants how long that they would recommend that a cardiovascular resuscitation effort should occur for those who do not obtain ROSC at the outset. And what's interesting in this result is that there was a difference between the length of time in which a respondent would advise of how long the resuscitation event should occur based on whether or not they already came in with the idea that the resuscitation event was either medically futile or non-medically futile. If the resuscitation event was considered to be medically beneficial or non-medically futile, the respondents on average recommended that the resuscitation event last for approximately 36 minutes. Whereas if it were deemed medically futile, the respondents advised for only approximately 20 minutes in length of time. So in reviewing the response in regard to the participants, whether or not they perceive that slow codes are to be ethical or not, what's shown here is that the majority, 52%, actually reported that slow codes can be ethical if the code is considered medically futile. And of this, 85% believe that the patient or the alternative decision maker, i.e. family, must be informed if a slow code is to be conducted, which is an interesting point to dissect a bit further. Again, emphasizing the vast majority of these respondents stated that slow codes, in their view, felt that slow codes could be ethical if the resuscitation events were medically futile. And the vast majority believe that if a slow code is to occur, they must inform either the patient and the family. Of the 46% of the respondents who reported that slow codes are unethical, 40% believe that no CPR should be performed in that situation. Whereas 60% stated ACLS should be performed because slow codes are unethical, and it should follow the AHA guidelines for ACLS. In this response, attendings were more likely than any other group to believe that slow codes were unethical and that ACLS should not be performed, which is an interesting question in regard to why attendings would respond in this fashion. And it would be curious, and this was not investigated in this particular study, but it would be curious to query whether or not the experiences led to this decision. Here, medical futility, just for a definition, was defined as the inability of CPR to correct the underlying known cause, and that CPR would most likely be unsuccessful, even if ROST is obtained. The next part of the results looked at the attitudes about slow codes from the respondents and medical futility, medical futile codes. The vast majority of the respondents here stated that ACLS can be deemed as to be considered medically futile in situations, and that healthcare workers should be allowed the opinion and support to not offer CPR. That was approximately 75% of the respondents. However, there was also a majority, 52% of the respondents, who also agreed that ACLS can be considered, or cardiovascular resuscitation can be considered to be medically futile. They also reported that slow codes could be beneficial, and it could be beneficial because it shows the family that everything is being done. And the majority also feel that we have a moral obligation to perform CPR when a family requests that everything be done. This next slide evaluated why slow codes occur. And slow codes occur for the most common reason why the respondents reported slow codes to occur, about 28%, was that the slow code would serve as a middle ground between what the healthcare workers, providers, and families think what is in the best interest of the patient. What followed next was, as indicated in the previous slide, that the family was requesting that everything be done. The next was just difficulty in communication. Finally, medical concern of medical liability, being sued by the families or the patients if they did not do a code. And the other was the idea of preserving trust. What's interesting to note, if you recall from the initial slide from Jessica Mueller, is that there are several commonalities between the two, between 1986 and 2021. We see that reaching that middle ground, family request, and difficulties in communication, those are still reasons that are being maintained as to why slow codes continue to occur. This study also looked at moral distress. What is the moral distress that is felt by individuals who participated in a slow code? And what's outlined here is that you can see that there is a significant amount of moral distress that is experienced by both nursing staff, physicians, residents, and advanced practice providers. And of the participants, those who actively participate in the chest compressions and CPR had the highest reports of moral distress when they consider a code to be medically futile. What's also noted here is that if an individual didn't participate in the actual intervention, but also witnessed a CPR event that they felt to be medically futile, they also reported a high degree of moral distress as well. The attendings were less likely than nurses and residents to express symptoms of moral distress. And what's also interesting, looking at the demographics of the respondents, is that there was a higher percentage of providers who identify as Black or Hispanic, who expressed a higher level of moral distress, approximately 75 to 80% when compared to our white respondents. in this survey. So it's interesting to have a conversation about recognizing that slow codes continue to exist, that there are differences between how we evaluate whether or not a slow code exists and what our participation is in communication, establishing whether or not code discussion occurs. In talking about code status, the healthcare providers, when we meet our patients for the first time, we are required to discuss code status. It is helpful to establish what our code status is for our patients and have those conversations. You can imagine, however, in a very busy inpatient hospital unit, that those conversations can sometimes be challenging for a variety of reasons. And sometimes we do not simply have the luxury of being able to have a long conversation in regard to code status. As an intensivist, I'm often required to, in a very short time frame, make a decision about medical futility or medical or the idea of non-beneficial medical care in patients who have a very quick clinical deterioration. And in thinking about how we have these conversations or how I come to these medical decision-making with these patients, I do follow, as we all do, the AMA Code of Medical Ethics, which outlines that physicians and healthcare workers are not obligated to provide care that we determine to be medically inappropriate or non-beneficial. Given that last slide, which indicated that there was a high level of moral distress that it was felt by nursing staff, it's really important to call out, however, that although physicians are not required or not obligated to provide clinical care that is non-beneficial, our nursing colleagues have to act within their standards of practice, and they're required to execute the physician's orders. Otherwise, they risk putting their license at risk. So it's an interesting dynamic in which can oftentimes cause tension between the healthcare teams, because again, as what's outlined, when I'm supported by my clinical practice in not being obligated to provide clinical care as a physician, as an intensivist, the nursing staff may feel differently, and that can cause some distress amongst the healthcare team. So something to think about as we have these conversations at the bedside. So in reviewing the principles of slow codes, we have on the one hand, some individuals who support that slow codes are ethical. It can help the family to cope, and it can help the family understand that everything was done by the healthcare team if the patient clinically deteriorates and dies. But on the opposite end, the ethics intention, if you will, is that there are groups of physicians and healthcare workers that believe that it is unethical to provide a slow code. It doesn't honor the core principles of medical efforts. It doesn't provide benefit for the patient, and it does not prevent harm. Quite the opposite. It can be quite traumatic. It can be considered to be deceitful, paternalistic. It can erode trust in the relationship between the patient and the physician, the patient and the physician, and the family and the physician. So there is very much a belief that slow codes in this practice can be harmful and deceptive. It can also be considered to disregard the patient and the surrogate autonomy and deprives the opportunity for a dignified and peaceful death. Despite this, despite a broad literature in regard to slow codes and the ethics behind it, there's no current consensus on whether or not slow codes are ethical or non-ethical in medical practice. And as I was preparing for this talk, I came across a very interesting article by Dr. Foreman, Why Not a Slow Code? And in this particular article, they discuss a case in which a patient it was a newborn, had such profound birth defects that they were not going to survive life after delivery. And the patient's parents had requested that the neonatologist do everything. And that was in contrast to what he, as a neonatologist, and the rest of the medical team felt was appropriate. They knew that the newborn baby was not going to survive. And so Dr. Foreman considers in an ethical framework, is there a possibility to find some balance? We oftentimes think about DNR or code status as do everything or do nothing. So what about a middle ground? And as was outlined in the most recent study, there can be a space for a middle ground. Rather than having a conversation about a slow code, Dr. Foreman puts forth that changing the terminology to think about what is a limited resuscitation or a limited time trial in those situations in which the healthcare team feels as though the resuscitative efforts are going to be non-medically beneficial. From an ethical standpoint, it could be beneficial to the family, again, to see that everything is being done. But if the family and the patient are approached with some things can be done, any time-limited trial, this could be that ethical middle ground in which the families, the patients feel supported, and we maintain our appropriate ethical framework for how we think about the delivery of care of our patients. Limited, less aggressive measures could be offered, but only if the physician who's having that conversation feels as though that there is some benefit over the burden, and that benefit could be meaningful. Having this conversation about a limited resuscitation trial allows for shared decision-making to occur between the family, the patient, and the healthcare team, rather than a more paternalistic approach. So, it's September 2021, and I'm talking about codes and slow codes. I would be remiss if I didn't talk a bit about codes during the time of COVID. As Jackie introduced me as, I'm an intensivist here. And so as the COVID pandemic began, unfortunately last early spring, 2020, myself and many of my colleagues were asked to participate in committees in which we thought about the provision of care and how to provide care for our COVID patients while limiting and protecting our healthcare workers. And so myself and many others on this call participated in a couple of different committees in which we created some pathways, guidelines, and policies, if you will, to help inform how we could have advanced care planning discussions and decisions about do not resuscitate patients during the time of COVID. What's listed here, or what's shown here, is an article that really helped us to frame the conversations surrounding the policies and procedures that UC Health put into place to help support healthcare teams at the bedside. And this is a link, it's on the source, that provides a variety of policies that helped healthcare teams, particularly during times of extreme stress, think about the conversations with families, conversations with patients who are extremely sick, and how we thought about providing critical care to the best of our ability in an ethical and kind fashion. What's shown here are the patient decision aid tool that was created to help providers with tips in regard to how to have conversations with patients, particularly during this, particularly for those who had been diagnosed with COVID. Now, in the interest of full transparency, this was also during a time where we were considering whether or not our healthcare system was going to be so overloaded that we would have to think about crisis standards of care and what life support measures that we could provide for patients, as we thought about what are the limited resources, not only from a mechanism standpoint, mechanics, ventilators, dialysis machines, but of course, staff as well, physicians, respiratory therapists, and nursing staff. There are a variety of resources that are available to help the healthcare teams, particularly on the inpatient service, help to navigate difficult conversations with patients in thinking about what are the provisions that we can provide in regard to extremes of healthcare. I've utilized my ethics consult colleagues quite frequently. They can help to reconcile disagreements between the healthcare team and our families. They can also provide that neutral dialogue that helps separate the primary clinical care team and the family. I don't know where I would be without the spiritual care services. Whenever I'm in the ICU, I always know who is on call, so I can ask my chaplains to come to the bedside, oftentimes for moral support for me, but to help with families as well, of course. And of course, our palliative care colleagues are an amazing resource that we can all utilize. It has a role in shortening ICU and hospital length of stay for patients, particularly in thinking about what is the quality of care and what are their values that the patients need to and the families need to think about when they're in our ICUs. And so I oftentimes utilize them when I'm too focused on thinking about the bedside clinical care, the physiology, the pathophysiology, and my palliative care colleagues can remind me that I'm not just taking care of a patient with ARDS, I'm taking care of a holistic human who has families and has interests and has values. So they are an amazing resource when I become too focused in my lens of providing clinical care. So let's take a step back and get back to my patient R. Now, in the interest of full disclosure, I took care of this patient approximately 2 weeks ago. And during hospital day 11 through 16, as I had already mentioned, he had developed severe ARDS, severe refractory acute hypoxic respiratory failure. Unfortunately, between these days, hospital day 11 and 16, he was so severe that he remained paralyzed and prone. We were unable to place him into the supine position because he would clinically deteriorate and become too hypoxic. Despite remaining in the prone positioning and maximal medical support, his oxygenation status could only be maintained to high 70s to mid 80s, and this occurred over the course of 5 days. So every day between day 11 and day 16, we had discussions with his wife. He had no children. It was just he and his wife. We walked her through what the presumed prognosis would be. We answered all of her questions. We provided support with compassion and empathy. We tried to explain as kindly and concretely what the concerns were from a clinical standpoint, that her husband was not going to survive this ICU stay. And on our daily team rounds, I also took the opportunity to speak with the nursing staff, respiratory therapists, and the medical residents, and our acting intern or medical student to talk about how to approach this patient. He was full code, and in the interest of full disclosure, he was not in our medical intensive care unit. He happened to be in our COVID ICU. So unfortunately had severe COVID pneumonia ARDS. And during our daily conversations, after we reviewed the clinical care for the day, We spent anywhere from about 15 to 20 minutes talking about what were the ethical constructs that were informing how we were approaching our conversations with the family, our conversations with his wife, how we were thinking about providing the provision of care. And we did our best to walk through all these components on a daily basis. We spent a lot of time again with his wife, trying to get her to understand that what we were providing from a medical standpoint was no longer benefiting him. And it was becoming harmful. He began to have skin breakdown. He began to display some of the side effects of being on some of these medications. She continued to tell us that she believed in miracles. And I used my classic line that I use, the miracles that we pray for are not always the miracles that are provided. And ultimately, as the attending physician and had multiple conversations with her, I informed her that what we were providing was no longer medically beneficial and it was medically harmful to him. So we asked her and her nephew to come to the bedside, and we had stopped the paralytic and we placed him in the supine position. We had spiritual care at the bedside, and we allowed time for her and the nephew to be with Mr. R. I had informed her that if he began to clinically deteriorate, we would accelerate comfort care of end of life. I was so concerned that when we placed him from the prone position into the supine position, that he very well may have a cardiac arrest. So I wanted to provide her informed assent that I would not be providing heroic cardiovascular resuscitation efforts. Thankfully, that did not occur, and she was able to spend time at the bedside. Once his oxygenation status began to worsen, at that time, we made the decision to move him from his support to comfort care, and end-of-life measures were employed. And he passed peacefully with his wife at the bedside. So with that, that concludes my talk. And I hope that through this talk, you've been able to hear that slow codes, they continue to occur. They are still maintained in clinical practice. The common reason or response as to why they continue to occur is the healthcare providers, the healthcare team are trying to find that compromise between what the family believes is in the best interest of the patient and what we believe to be in the best interest of the patient. I hope you've been able to understand that the majority of healthcare workers do agree that slow codes can be ethical. And that moral distress is very common and is felt in when an individual participates or observes resuscitation efforts. And maybe slow codes we should reconsider as focusing our communication and our support from a medical practice at thinking about the terminology away from slow codes to limited resuscitation efforts. So with that, I thank you for the time that you have all spent today. And I am happy to take any questions that may have come up on the chat. It does look like there is a variety of comments that I haven't been paying attention to, but I hope I'll be able to answer your questions. So thank you for your attention.
Oh, thank you, Dr. Laura. We have had an interesting dialogue in the chat, and how can a lie ever be ethical? To it's palliative and transitional. So that has been occurring. And the questions are about two major questions. The first one is about the use of language, which is great. New grad RN saying, I'm in the ICU, we do our own codes, but on the floors, they use the language of soul code to talk about the efforts being done to avoid actually a code situation. Can you say something about that? And then how do you describe it? to a family? What's the language that you use to describe it? And what's the language of this limited, feudal language? That's a really scary word. We don't think our loved ones are feudal, and we don't like that language. So the other conversation is about unilateral DNIRs. In COVID, you talked about COVID, and there's some discussion about, rather than lying and rather than putting them on the family, why don't you just use unilateral DNRs? And by the language, why do we still use DNARs? Why can't we shift to allow natural deaths? So talk about the language and then talk about unilateral.
Great. Yeah, thank you. So those were a lot of questions. So hopefully I can answer each of those questions. So in thinking about the language, so as my title shows, one of my positions is I co-direct the Office of Professional Excellence for the School of Medicine. And I've been in this role for 3 years, and I can share with you that the conflicts that occur all surround communication and language and words. And tone, and in particular, how do we manage conflict? So when I think about approaching patients in regard to code status, and there is a conflict or a disagreement between whether or not heroic resuscitative efforts should be employed, when I think that CPR will be medically non-beneficial. By the way, I much prefer the language of non-beneficial as opposed to futile. I find that being direct and being concrete is kind. I also take the time and effort to develop rapport and trust. I try to understand the viewpoints and the values that that patient or that family are bringing to the conversation, and what is motivating their decision to ask for everything to be done. That's number one. I also find that it is my responsibility to take the time to help families and to patients understand, what does it mean to have everything done? Being on mechanical life support or life support, I feel is a very important discussion point, to be very clear with the families and the patients what that means. When you are on life support, what we do is we put a plastic tube in your throat. We use a machine to breathe for you. We use a machine to clean your blood. We use medications to maintain blood pressure, and spending quite a bit of time with family members so that they understand what life support means is a critical aspect that I actually begin with before I even get to what their code status is. The reason for that is, when we think about a cardiovascular resuscitation, it is an intervention, right? So it is an intervention that is done in order to preserve life. CPR, cardiovascular resuscitation, has its history, has its beginnings in the operating room, where cardiac surgeons had to stop a heartbeat in order to perform surgery. CPR began during this time where the cardiac surgeons had to squeeze the heart to bring back life after they were taken off pump. So it's now become an intervention. It's a procedure. So we've taken away and we've interrupted what could be considered the natural process of death. And we've offered to patients that we can stop death. So the reason why I start with explaining to them what life support is that it gets the patients and the families to understand what it means when we do everything. Then, in talking about cardiovascular resuscitation, being very specific about all the interventions and what our guidelines are for ACLS, I think is also important. I do not use language of slow, and the reason for that is because it has all of the weighted judgments that we have with it, and it's not helpful for families to understand in regard to when they're making a decision about whether or not a code should occur, or if a code should occur. Let's see. When I have the conversations about having a code, doing a code, or heroic cardiovascular resuscitative efforts, when I think it's not medically of benefit to a patient, I always take the ethical framework and remove, when I think about who is it benefit, and I remove the medical benefit from it. It is helpful. It can be helpful for patients to see that the healthcare workers do everything for their loved ones. We recognize it can be morally distressing for us, those of us who do codes, to perform cardiovascular resuscitative efforts in a 101-year-old person. We recognize that. However, in those situations, I do take the framework of, if this is what the family is desiring, or if this is what the patient is desiring, can I find that middle ground? And I will use the language of limited resuscitation efforts. We will do X for time frame Y. If we have not been able to establish cardiovascular hemodynamics, then we will stop. Another aspect of benefit, I think, for family members as well is in performing CPR that we deem to be medically futile could potentially be of benefit for family if there is family members that want to come to the bedside to be able to say goodbye. So I think that's another aspect that I take into account when I'm thinking about the terminology and the reasonings why family members or patients would want these heroic efforts to occur when I deem them, or when I find them to be medically non-beneficial.
So
there was one other question and I missed it.
Yeah, in answer to the question, you don't use the language of slow code. You use limited resuscitation and being very concrete.
Yes.
So how does this all play out, the communication, which is at the heart of it, in an era when families are in? When you start the code, families are there. How does that work?
Oh boy. Yes. So when families are not at the bedside, and I haven't had the ability to be able to have that conversation with them, which does occur with some regularity in the hospital, I start the medical decision making from the framework that the patient is full code. We are going to be doing everything, and that is medically beneficial in that moment. And it's important for somebody on the code team to identify who the family is and try to get in contact with them to have the conversation that this is occurring. And so it can be very, very complex to do in a timely and in a timely fashion. But when myself and my other colleagues are on service, we try to identify that family member so that we can at least get them on the phone, update them that what is occurring, and to try to get them try to have a shared decision making about either the length or progression of the CPR event. I remembered the last question that I was asked is the unilateral code status. Yeah. So not all hospitals have a policy in regard to a unilateral DNAR. I think that because there is not a consensus in regard to making a determination of whether or not time-limited codes are ethical or not, as well as you can have a difference of opinion upon whether or not, you can have a difference of opinion between two individuals as to whether or not a resuscitative efforts is medically beneficial or not. Two individuals, same experiences. And so it can become challenging to make that unilateral DNAR a hospital policy, because there are so many different ways to be able to think about from an ethical framework whether or not they are of benefit. Medical benefit versus the benefit from the lens of the family is just simply too challenging.
Our friend from Arizona, Patty Mayer, has brought to our attention that Nevada has declared crisis standards of care, and their unilateral DNARs are in effect. Is that correct, Patty?
Jackie, their crisis standards of care were activated a long time ago, and they had that statement in there about COVID positive patients who are intubated on vasopressors, that it can be an automatic DNR. My system has a facility in Nevada, and it's not at all clear to me that the physicians are actually doing that. Mm-hmm. But by law, they could.
Mm-hmm. The state of Colorado has not, and our governor has not had to sign the crisis standards of care. I can remember, a year and a half ago when we were thinking that we were close, just thinking about not being able to provide that high level advanced life support, and having those conversations, even for someone like me who's been in practice for almost 20 years, imagining having that conversation was, from a compassionate and empathic standpoint, felt incredibly stressful. I will say this, our hospital system and School of Medicine, our colleagues were great at being able to come together and create policies, procedures, and tip sheets to help support the bedside clinicians and nursing staff, et cetera, so that they had a resource that they could turn to and be guided by, as opposed to making their individual decision. I'm hopeful that our current surge will not get us to a point where we have to think about crisis standards of care. However, well, I guess COVID is here. I don't know what else to say about it.
So last question. I love this discussion about language. We went in my lifetime from DNR, do not resuscitate, to DNAR, do not attempt resuscitation. And there's some resistance to the palliative care world of allow natural death. So I'm going to ask Abby if you could respond to that, and also Jeannie or any of our palliative care colleagues on to respond to this pros and cons of changing language yet again.
Oh gosh, that is actually something that if Dr. Youngworth is still on, that I'll ask her to begin that conversation. Because I will say that I think that you're absolutely right. Language is so critically important. DNAR versus DNR versus full code. I guess I'm certainly not the content expert. So like I said, I'm going to punt this over to my colleague and friend, Jeannie, if she's still on.
Thanks, Abby. I'm a fan of allow a natural death. I think it's language that people can understand. I think whatever form of DNR or DNAR that you use, it's something that people have a very hard time wrapping their head around what we're actually talking about. And I think a lot of times when you use the language of DNR or DNAR, it almost sounds like a choice of asking patients or families if they want to live or they want to die. And that's not what we're talking about. We're talking about how, when a person does die, that they see that time around then and what we are focusing on during that time. And I think allowing a natural death tends to match that.
Thank you, Jeannie. So we're almost out of time. Thank you, Dr. Laura, and all the participants in the lively chat. And people have been sharing resources about if you want to talk to your families. There's a lot of resources. There's some resources on the Center for Bioethics site, including this recorded session. And see you again next month, Thursday, October 14th at noon for a discussion with Martha Gershon and John Lantos about altruistic kidney donation from the perspective of Martha, who was an altruistic kidney donator. So thank you very much, and see you next month, October 14th, for altruistic kidney donation.
Thank you, everyone. Have a wonderful afternoon and be well.